All right, welcome back. In this part 2, we are diving deep into how to actually manage female urinary incontinence. We're going to break down the clinical algorithms you absolutely need to know from the very first things you do all the way to advanced procedures. Seriously, this is super high-yield stuff, so let's get right into it.
So here's our game plan. First, we're going to build out the treatment pyramid. That's our whole framework. Then we'll do a deep dive into managing urgency incontinence and then stress incontinence, because you treat them very differently. We'll also touch on some of those trickier mixed and overflow scenarios, and then we'll wrap it all up with a quick, high-yield summary to make sure it all sticks.
First up, let's lay the foundation. These are the strategies we start with for pretty much every single patient. They form the essential base of our treatment pyramid.
These are the absolute first steps. Before we even think about a prescription pad or a surgical suite, we start right here. And they're incredibly powerful. For patients with obesity, just weight loss alone can be a huge game changer. I mean, there was a landmark study that showed an intensive weight loss program cut the number of weekly incontinence episodes by nearly 50%. That has a massive impact from just a lifestyle change.
Okay, let's talk about pelvic floor muscle training, or what most people call Kegels. This is a cornerstone, first-line therapy for both stress and urgency incontinence. So why is it so great? Well, by strengthening those pelvic floor muscles, you get better support for the urethra, which helps stop stress leaks. And, at the same time, those strong muscles can help inhibit the unwanted bladder contractions that cause urgency. It's like a two-for-one deal.
And for our postmenopausal patients who have genitourinary syndrome of menopause, you have to think about topical vaginal estrogen. Now listen, this is a really key point. We're talking about topical, local therapy right in the vagina. It helps restore the tissue, improves the seal of the urethra, and can make a big difference. This is not the same as systemic hormone therapy, which can actually make incontinence worse.
So here's how it all fits together in our treatment pyramid. We always start with that wide, sturdy base. Lifestyle changes, behavioral therapy, and Kegels for everyone. If that's not enough, we climb up to the next level. Medications or maybe some mechanical devices. And only at the very top, for the toughest cases, do we start considering surgery and other advanced procedures. Okay, so let's climb up that pyramid and tackle our first specific pathway, managing urgency incontinence. The overactive bladder. The entire goal here is to calm down that hyperactive detrusor muscle. So, after a patient has given bladder training and Kegels a really good try, and they're still struggling with that gotta-go-now feeling, we move up to medications. The target for these drugs is the detrusor muscle itself. Our goal is pretty simple. We either block the signal that's telling the bladder to squeeze, or we actively tell it to relax.
Okay, this is a classic, super high-yield comparison for your boards. On one side, you've got the Antimuscarinics, like oxybutynin. They work by blocking the M3 receptors on the bladder, basically telling it stop squeezing. But they come with all those classic anticholinergic side effects: dry mouth, constipation, and, this is a big one, confusion, which is a major no-go in our elderly patients. On the other side, we have the Beta-3 Agonists, like Mirabegron. They work differently. They hit the Beta-3 receptors to actively promote relaxation. The huge advantage? They avoid those anticholinergic side effects. The downside? You've got to watch their blood pressure.
So what happens when the oral meds don't work, or the side effects are too much? We're not out of options. We move to third-line advanced therapies. This includes things like injecting onabotulinum toxin A, yep, that's Botox, directly into the bladder muscle, or using neuromodulation, which is kind of like a pacemaker for the bladder nerve. All right, let's totally switch gears and tackle our second pathway, managing stress incontinence. This is that leakage with a cough, a sneeze, or a laugh. And unlike urgency, this isn't a bladder spasm problem. This is a mechanical problem. Think of it like a leaky valve. So the treatments, they're completely different.
So listen up, because if you remember just one thing about stress incontinence, let it be this. There are no FDA-approved medications for it. I'll say it again. You do not treat pure stress incontinence with drugs. The management is either mechanical or surgical. This is a super common clinical mistake, so don't let it be yours.
So for patients who want to avoid surgery, or maybe they just aren't a good candidate, we've got some fantastic non-surgical options. We're talking about things like continence pessaries or even some over-the-counter inserts. They all work by providing physical support to the urethra from inside the vagina. This is perfect for someone who, say, only leaks when they go for a run. They can just pop it in before exercise.
Now, when we do move to surgical options, the undisputed gold standard is the mid-urethral sling.
And the concept is just beautifully simple. It's a small strip of mesh that's placed right under the middle of the urethra, and it acts just like a supportive hammock.
So how does this little hammock actually work? Well, when intra-abdominal pressure spikes, from a cough or a jump, that pressure pushes down on the urethra. But now, instead of leaking, the urethra gets compressed against the sling, which acts like a firm backboard. It basically pinches the urethra shut at the exact moment it needs to be. It's a really effective, long-lasting mechanical fix.
Now, a less invasive alternative to the sling involves using urethral bulking agents. The idea here is pretty straightforward. You inject a gel-like substance into the tissue around the urethra. This bulks it up and helps it seal shut more effectively. It can be a good option for certain patients, especially those who can't tolerate a bigger surgery. But you have to counsel them that the cure rates aren't as high as a sling, and they'll likely need repeat injections down the road.
Okay, real quick, let's touch on the more complicated scenarios. Because, not every patient fits perfectly into one of these boxes. We have to know what to do with mixed and overflow incontinence.
When you have a patient with mixed incontinence, so they have both stress and urgency symptoms, the game plan is to treat whatever is bothering them the most. And what's really interesting is that if you place a mid-urethral sling to fix their stress component, it often improves their urgency symptoms too, in more than half of patients. Now for overflow incontinence, where the bladder just gets too full and leaks, it's all about playing detective. You have to find and treat the root cause, whether that's an obstruction you need to relieve or a lazy bladder that needs to be emptied with a catheter.
All right, let's bring it all home with a super high-yield summary. If you've been zoning out, this is the time to tune back in. This is what you absolutely need to remember.
Here it is, the whole algorithm in 4 simple steps. 1. Start with lifestyle and Kegels for absolutely everyone. 2. If it's urgency incontinence that persists, you think meds, either an antimuscarinic or a Beta-3 agonist. 3. If it's stress incontinence that persists, you think mechanical, a Pessary or a Sling. And 4, I'm going to say it one last time, do not use medications for pure stress incontinence.
And to leave you with one final thought, a little clinical challenge for you. You have an elderly patient with urgency incontinence and maybe a little bit of cognitive impairment. Which class of medication are you going to reach for first and why? Think back to those side effect profiles we just talked about. This is a super common scenario, and getting this right is huge for patient safety.